afternoon. So, so I'm just going to do a very brief introduction of Dr. Mohammed Hisor III, who is our speaker this afternoon and is going to just take us through an introduction to thoracic radiation oncology. Um, he completed a Bachelor of Arts from Columbia University in 2013, has worked with medical devices and pharmacogenetics. He's then gone to the School of Medicine, the Icahn School of Medicine in New York City, graduated with honors as part of the Gold Humanism Honor Society in 2018. Has trained at Northwell Health, completed his residency at between Cornell and Oregon Health and Science University, has participated in global health projects, including a grant for work on radiation therapy education and collaborative research on cancer in Gabon. He has published multiple book chapters and articles on a range of subjects from GYN cancers to high-dose radiation for liver cancer. So he's board certified through the American Board of Radiology, an adept at external beam stereotactic body radiotherapy and stereotactic radiosurgery. So today is going to be taking us through an introduction to thoracic, radiotherapy. So welcome, Dr. Hisoro, and thank you very much for speaking with us today.
Absolutely. Thank you for the invite, and happy to be on the call with everyone here. So, my hope today is to go through both non-small cell and small cell lung cancer. Of course, there are other malignancies that can occur within the thoracic cavity that we'll all have to treat, but these two are, of course, some of the larger ones that comprise most of the patients. And so hopefully we can go through on a case-by-case basis for some of the most common presentations of non-small cell and small cell lung cancer. So part of my outline today, I'd like to go over the indications for radiation therapy in these malignancies, as well as some of the management, including imaging and staging, and some of the diagnostic workup that we should all consider. The multidisciplinary management of thoracic malignancies is, of course, of primary importance, and especially for some of the locally advanced non-small cell lung cancers. And so we'll go over some of the interactions between specialties in that setting. And I'll cover some of the fundamentals of radiation therapy planning. Of course, I think, if I remember, I believe it's the lecture should last somewhere around an hour in time. And so I'll go into as much detail as I can, given time allotted. So first, very, very briefly about the epidemiology of lung cancer. We all, of course, know how important it is. It's the number one cause of cancer death worldwide. And I believe some of the updated estimates are somewhere in the 2.5 million range of 2.5 million of new cases, and somewhere around 2 million cancer related deaths. 85% of cases are attributed to smoking, although, of course, as we all know, there are other risk factors, including environmental, such as radon. 70% of patients may present with locally advanced or even metastatic disease, which in part explains some of the high death rates for this disease. Adenocarcinoma and small cell lung carcinoma squamous cell carcinoma are two of the primary type of histologies that we'll see. Some of the histopathological findings for adenocarcinoma and squamous cell are listed here, although frankly, I lean on my colleagues in pathology to help us discern. But some of the things that I'll look for on the slides and presentations that they'll give are some of the palisading appearance that you can see for squamous, and then some of the enlarged nucleoli that you may see in adenocarcinoma. Of importance, EGFR positivity and PD-L1 really does help guide us as far as primary treatment, adjuvant treatment for a lot of our non-small cell lung cancer patients. And so, if available, these things can really help guide our management. Overall survival based on the stage of diagnosis. This is a little bit dated. I think it's from one of the seminal textbooks that many of the radiation oncology trainees use in the US based off of findings from Hansen and Roach. They were both based out of the University of California, San Francisco, and really had a almost an outsized impact on many of our educations. But skip through. So for stage one, the number that I like to remember is something around 50%. Now that's I do think that that's a little bit dated to some of the stage 1As, and especially stage 1A ones and twos can have a much higher overall survival on the order of 90%, depending on the management of those patients. But skipping from stage 1 down to stage 4, it can be as low as somewhere in the single digits in the long term. To briefly go over staging, I don't think that there have been any large changes as compared to the prior 7th edition. We use the AJCC staging, and the size criteria is of primary importance from 1 to 3 for the T1s, at 3 to 5, 5 to 7, and over 7. Invasion and presence of separate nodules, either within the same lobe or in a different ipsilateral lobe or contralateral lobe, will help define sort of higher stage disease of T3, T4, or even M1 disease for the contralateral lobe sites. Although, to be honest, I think there are many multidisciplinary tumor boards here where a patient may present with, let's say, a right lower lobe and a left upper lobe nodules that have been biopsy proven and consistent with non-small cell lung cancer, either squamous or adenocarcinoma. And oftentimes those patients are actually staged as separate T1 tumors, and then are managed accordingly with primary definitive treatment for both. And that can be a combination of approaches for that. As a very, very, very brief overview of non-small cell lung cancer treatment by stage, typically surgery is one that we think of for primary management of a smaller localized disease in a fit patient with a very low burden of comorbid conditions. But if for whatever reason the patient is either medically inoperable or by patient choice, oftentimes will, in a multidisciplinary setting, have consultations with both radiation oncology and thoracic oncology. And for a patient who may be a candidate for either radiation or surgery, and patient choice, plays a large role in what modality they ultimately choose and undergo. Stage 3 lung cancer, non-small cell lung cancer. I think in summary, the stage 3A non-small cell lung cancer patients are often treated with a combination of a neoadjuvant approach and surgery, if not just upfront surgery, if that patient is eligible for that. But for the later stage 3 patients, stage 2B and C, oftentimes they're treated with just definitive chemotherapy and radiation. And of course, there are some indications for adjuvant therapy depending on findings at the time of surgery, for example, an incidental N2 patient. And then stage 4, of course, is a primary systemic disease, and radiation in that setting is often used for palliation. Now with trials like oligomez and Saber Comet, I think there are a subset of patients with oligometastatic disease that are technically stage 4, but may be treated with more definitive intent from a radiation standpoint. Given time, we won't go over that too much, but in summary, still the backbone of treatment, of course, would still be systemic therapy with things like EGFR and PD-L1 that we just briefly went over, helping to guide us. And then a very brief overview for small cell lung cancer treatment. For limited stage, we think of concurrent chemo RT with varying um, doses and fractionations, but most commonly in the U.S. is a is a standardly fractionated regimen. It's over 6 weeks based off of the Convert trial. It'll look like something like 6 to 6.5 weeks of concurrent chemo RT. Some do still elect. I think something like 25% of patients here will still undergo the BID treatment, and that's still the one that I use, which is the BID treatment for patients who are able, and I'll typically go to concurrent for patients who, for whatever reason, can't make it to the office 2 times in one day over a period of 3 weeks. And then based off of newer data, with Adriatic being published recently, these patients will be followed with adjuvant durvalumab. TCI, prophylactic cranial irradiation for the limited stage small cell lung cancer patients, is a little bit more of a discussion. So I hope to get into that further down in the presentation. And then, of course, extensive stage, similar to non-small cell lung cancer, diffuse non-small cell lung cancer is typically a systemic sort of treatment, and then palliative radiation as necessary. Unlike non-small cell lung cancer, there hasn't really been, a cohort of patients that has been isolated and found to benefit from more definitive approaches with ablative radiotherapy and extensive stage small cell. So this one truly is almost universally palliative, as indicated. Lung cancer screening is something that we had initiated here, and I think it's almost everywhere in the U.S. now. I'm sure there are pockets where the low dose CT screening isn't available, but for the most part, many of our patients are undergoing this. These are for patients who have essentially decades long smoking history and smoking cessation recently. So in the past 15 years, I think. And those patients will undergo low dose screening for non-small cell lung cancer, and depending on findings, we'll get follow up as needed. And the NCCN, the National Cancer Comprehensive Cancer Network, has helped define in their guidelines approaches for follow up. Depending on what the findings are with regards to size or solid component versus patchy sort of ground glass opacities or mixture of both. So for a case for a 62-year-old who comes in with a sub-centimeter lung nodule and undergoes a low dose lung screening CT, they're followed as according to guidelines, and on subsequent CT later finds that the nodule is now a centimeter in size. So PET CT, as far as workup for these patients, can be extremely useful, both from a radiation planning perspective. We do use it, and is extremely helpful for us to isolate the lesion. We will often be able to fuse that PET CT with our planning simulation CT, and then at the same time we can evaluate the risk for nodal metastases for patients who don't undergo lymph node sampling, and then of course for systemic staging as well, to make sure that this truly is an isolated lesion. So down here for this patient, this right lower lobe nodule just above the liver without anything else obvious. The next step for us is to undergo PFTs, or pulmonary function tests. The numbers that we really look for from a radiation oncology standpoint as far as safety is to look at the DLCO and FEV1. Those two have been most correlated with potentials for toxicity. And so the magic numbers for us for the DLCO and FEV1 both are 40% or above. It isn't as though a DLCO less than 40% or an FEV1 less than 40% would be an absolute contraindication to definitive treatment. And so we do, and I have treated patients with lower numbers than this. But ideally, the idea is, of course, that and we borrow it from our surgical colleagues, which is, ablative radiation, as focused as it may be, will still leave some lung parenchyma essentially useless after completion of treatment. And so we need to understand the lung function of the patient, and what residual lung function they may have after definitive treatment, either surgery or with radiation. And so we'll also look at other comorbid conditions, pulmonary hypertension or diabetes with or severe organ damage or other vascular diseases. May also help us define absolute risk for either treatment modality, radiation or surgery. And our next step would be to proceed with pathologic confirmation. Of course, sometimes things may look more aggressive or malignant appearing on imaging, but not necessarily will be found to be malignant after path is obtained. So it is really important for us to do so. Now, that said, there are certainly patients with longstanding smoking histories, really poor primary lung pulmonary function tests, who may be at very high risk for something like a CT guided transthoracic biopsy, or even to undergo anesthesia for a navigational bronchoscopy, to get to the lesion and to prove malignant disease definitively. And so there are times where patients with a very high pretest probability for primary malignant lung cancer will undergo definitive radiation treatment. These are typically not patients who would be candidates and medically fit for surgery. And we just have conversations with the patient about the benefits and risks of proceeding or sort of what we might call a clinically diagnosed non-small cell lung cancer. I do prefer, and I think other practitioners do here too, that patients who elect to undergo the definitive radiation treatment for early stage non-small cell lung cancer do undergo a lymph node evaluation prior to completion of definitive treatment. The reason is, for patients who undergo some sort of surgery like a wedge resection or a segmental resection of the primary tumor, the benefit of the invasive approach is that those patients are able to simultaneously undergo a lymph node sampling evaluation, and especially for patients that may have larger early stage tumors that are more central, where the sensitivity of PET scans may not be as high. That can be the lymph node evaluation prior to completion of definitive radiation treatment can be extremely useful. And here's just a brief slide denoting and reminding us of the different approaches to lymph node evaluation. I think one of the procedures that stand out to me is the Chamberlain procedure, and the sort of the thoracic entry point and sternotomy being the only way to get to the 5 and 6 lymph node stations. But typically our patients without, that would correspond to a left upper lobe, essentially tumor that would drain there. Typically our patients, if PET scan has been completed and there hasn't been, any evidence suggestive of involvement in that region, our patients will undergo an EBUS and FNA as sort of the most commonly utilized approach to lymph node evaluation. And that's just because it can be a little bit easier on the patient to undergo something like that, as opposed to, let's say, a cervical approach or or a transthoracic approach to lymph node evaluation. Options as far as surgery for early stage non-small cell lung cancers, wedge resection and segmental resection are the two most commonly utilized. But for some patients who may have involvement of either multiple segments or of multiple components of the secondary bronchial tree, those patients may undergo a lobectomy instead if the surgeon isn't able to get it out fully by a smaller surgery. Pneumonectomy, of course, is only utilized in sort of extreme circumstances of more widely diffuse disease. And so here's a summary of our workup for our early stage patient example, a 62-year-old. So CT chest and PET CT. Of course, you could have always proceed with a CT chest, abdomen, pelvis instead if PET for whatever reason was unavailable. The MRI of the brain can sometimes be considered, especially for the more central lesions that may be a little bit larger, on the order of, let's say, 3 or 4 centimeters, just to rule it out. And then primary path path confirmation for the primary mass would be, of course, a primary consideration, and then the lymph node evaluation by one of those techniques that we went over. Pulmonary lung function tests are something that both the surgeons and the radiation oncologists are very keen on to ensure safety for definitive treatment. So in this example, for a patient who refuses surgery, SBRT would be an option, or an ablative approach to treatment. I think as far as the different methods for doses and fractionation for SBRT or SABR, those two can be used interchangeably. The most common would be the 5 fraction regimen. I believe most practitioners in the US will choose either the 4 or 5 fraction, but usually the 5 fraction regimen of 50, somewhere around 50 gray. And it's typically done either every other day or daily. So the patient would complete in either a week or a week and a half. The most of the early trials, including RTOG 0813, would do it on an every other day basis. But after utilization of SABR over the last decade or two, people have sort of grown more comfortable with the side effect profiles and proceed with and not infrequently proceed with the daily administration of this approach. The other ones can be utilized too, and it really, patient selection is of primary importance for some of the other ones, including the I believe it was RTOG 0236, the Timmerman 18 to 20 gray and 3 fraction approach. This trial, or these two trials, were, I believe, the best evidence, and not unfortunately didn't accrue to the extent that we'd like to feel more comfortable with its outcomes. But the best data that I know of, as far as comparisons between surgery and radiation in early stage lung cancers, and because they didn't accrue, there was something like 60 patients. They tried to essentially combine results of these two trials and compare things like overall survival and recurrence-free survival. I don't know that I necessarily believe at all, really, that overall survival was is better with an SBRT or a SABR approach as compared to surgery, especially at these patient numbers and incomplete accrual. But by and large, I do think that, looking comparatively at either the combination of stars, Rosal, or the individual literature databases of surgery and of therapeutic radiation oncology using ablative approaches in this in this context. The numbers do seem to be pretty sort of consistent between the two, meaning, you know, things like local control and local regional control might be on the order of 5% different, or something, maybe 5 to 10% different between surgery and radiation. But there's a lot of caveats in there with what type of surgery and the honestly what type of dose and fractionation and how it's administered, where the tumor is, and that sort of thing. But both are excellent options, I think, for these patients. So how would you treat them? So we treat them sort of lying on their back supine with an immobilization device. Typically, it's a board where the patient sort of lies on, and it's indexed, meaning every point along the patient's body is sort of numbered and recorded as far as their position on a board, such that it can be reproduced more easily. We do a 4D CT, which you know, allows for tracking of the tumor throughout the patient's respiratory cycle. And so, you know, sequential images are taken both as they're inhaling and exhaling, and as the tumor is moving and the rest of the organs in the thoracic cavity are moving, such that we get a good sort of composite image of all of the possible locations of the tumor, assuming sort of a respiratory cycle that, you know, is consistent between, you know, both our simulation scan and treatment. And there are different things that we do to ensure that. Sometimes we'll treat patients with breath hold. Now, typically, you know, our lung cancer patients are maybe folks who may have longer smoking histories, or and for whatever reason, medically inoperable from a, you know, pulmonary function, lung function test standpoint. And so some patients can't do breath hold, but for the ones who can, and there's a surprising number, I think, you know, despite some of the comorbid conditions that they may come in with, who can, breath holds can be another technique that we'll utilize. We will sort of delineate the gross tumor, and then that's what this stands for, the GTV, the gross tumor volume, and we'll sort of delineate that, and then we'll the most, well, frankly, actually, I don't know if it's the most common, but it's something that I do. I believe at Memorial Sloan Kettering they do something similar to, where they'll draw out what they define as an IGTV, which is the gross tumor as it moves, or as it's represented between either a 4D CT or breath hold. So for the breath hold scans, we'll ask the patient to do it maybe 3 to 5 times, and take images throughout those times. And this GTV will essentially be drawn on all of those images and then combined into an IGTV, which would represent its motion throughout either the breath hold differences between you know, the ways they do it each of those 3 to 5 times, or the 4D CT, and then that's expanded out to somewhere between 5 millimeters to 10 millimeters, or 0.5 centimeters to 1 centimeter. I think, you know, we often will work, each of the departments here will work with their own physics group to see what onboard imaging they may use, so imaging that's on the treatment machine itself, that they may use to help make sure that everything that we planned to happen at the time of simulation is in fact occurring when we're treating that patient. Typically, radiation dose and fractionations are of course critical in ensuring that we have a high potential for local control. But they can also be prescribed in many different ways, and one of the most common way, and which can have a subsequent very large effect on the actual radiation dose that's administered. And the most common way that we'll do it is 95% of the what we call the planning tumor volume, PTV. We'll get 100% of the dose, so the majority of the tumor getting 100% of the dose. Typically, it'll be something like 6 to 10 fields, different fields, and we'll treat with a sort of a modulated approach, similar to IMRT, but higher rate of administration, and then 6 MV photons, and usually 2. Some of the indices that we'll look at are conformality and heterogeneity. We want to make sure that the ratio of the dose that the ratio of the volume of the tumor and the ratio and the volume of the 100% of where the radiation dose is going are somewhere around 1.2. You of course want to make sure that the radiation dose comprises the entirety of the planning volume, but not too much so, So and the one of the most common numbers that we'll look for is around 1.2, and then heterogeneity. We'll want to make sure that generally less than 125% would be a good rule. So essentially, if you're prescribing, let's say 50 gray and 5 fractions, you don't want the hottest part of the tumor to go to something as high as, let's say, 100 gray, which might be a heterogeneity index of something like 200%. That makes sense. So we'll sort of want to keep it high to be ablative, and to make sure that we have a high chance of actually killing the tumor and having a high level of control, but not too high. So some patients may not be eligible for this ablative approach to radiation for early stage tumors, and so these include tumors that are either very, very large, like over 5 centimeters, so essentially like a T3 lesion, or patients who have maybe smaller tumors but are very close to the bronchial tree. Now, R20813 did help us define a dose and fractionation, that 50 gray and 5 fractions, that may be safe even for these patients, and so that's depending on how close and the sort of the appearance and what it may be invading or not, that'll help us define sort of what may be safer for these patients. So oftentimes, a 50 gray and 5 fraction may still be utilized, but there are other hypofractionated regimens, including the 60. This turns out to be 60 gray and 15 fractions. Or even sort of the 7.5 and innate that can be helpful too. So as far as patients who we do SBRT on, I think we reviewed this, but essentially patients who either may be medically inoperable or for whatever reason just refuse to undergo surgery. And some of our most common dosing fractionations are here, and then some of what we call constraints, or every normal organ in the vicinity of the tumor can only receive so much radiation that would then be deemed to be unsafe if they surpassed it, and so we have different metrics for that. And as far as our follow-up after SBRT, essentially these patients will be followed by CAT scans, and often what we see is, this may be sort of a typical example, is here, here's the radiation plan in sort of figure A of this, and B, it may look actually very, very similar. We often will tell patients that unlike surgery, we don't go in and actually remove the tumor, so you still see something there, and you do. And then in figures C through H, you'll see a natural evolution of what you may typically see in a patient who has undergone SBRT, who may still have the nodule. The nodule may almost appear to disappear before some patchy opacities start to develop in that same area, with morphology and location that is consistent with sort of its the radiation plan and the original tumor location, that then may develop into something more consolidative that may even look a little bit larger than initial. But the ideal is that after it reaches this stage, it doesn't grow anymore and doesn't change anymore. And that may be something like 1.5 to 2 years after the patient's been treated. So you'll see a natural evolution for quite a while afterwards. Some of the things that we look for: serial enlargement or craniocaudal growth. Oftentimes, these patients are treated with coplanar beams that are essentially, if you can imagine, axial slices, and the radiation beam following those axial slices. And so if we, for whatever reason, see growth in the craniocaudal dimension, that could indicate to us that that there could be some concern for sorry, I think my mouse just did that. Like there could be some concern for local progression. The patient refuses stereotactic radiation approaches. A more conventional approach could be used, even something like 70 gray at 35 fractions, which of course would have somewhat different dose constraints. The target volume would look very, very similar. So you still want to, have a 4D CT if you can. Ideally not breath hold, because then they'd have to hold their breath for quite a long time, or over a period of 7 weeks. And the expansions again would be, something that may be a little bit more departmental, just based off of each department's experience, and what you're actually using to immobilize the patients, and how you simulated them with 4D CT or not, and what kind of onboard imaging they have. But typically it might be something like 5 millimeters. As far as adjuvant treatment for early stage non-small cell lung cancer, patients may undergo chemotherapy afterwards if they are either N1 or very large, like T3. And a meta-analysis, was shown to have an overall survival benefit for these patients by 5%. So sorry, I got it. So as far as a summary, stage 1 non-small cell lung cancer workup includes CT and PET imaging, biopsy of the primary tumor and lymph nodes if you can, especially for patients who are undergoing a definitive radiation treatment and not surgery. For the surgical patients, that can be done at the time of surgery, and then primary lung function tests as well. So the adjuvant chemotherapy regimens that can be used for patients who are high risk, like those early T1 to T2 N1 patients, or T3 N0 patients, include quite a variety of different regimens, some of which are listed here. So for a patient who undergoes imaging, including, let's say, a chest X-ray, and then later a CT, and then finally a PET CT, who's found to have T2 N2 disease, they'd be categorized as a stage 3. What makes a patient a stage 3A versus a later stage 3, like a stage 3B or C? Well, for patients who have sort of smaller tumors but N2 disease, would be a stage 3A, like ours, like our example patient. For patients who have both locally advanced T and N staging, like a T3 N2, would be a stage 3B. And then only the most locally advanced, would be a stage 3C, like a T3 to T4 and N3 indicating sort of contralateral disease. So, for example, a patient with a left lung tumor and mostly left lung lymph node involvement, but also some right-sided or even supraclavicular. Oftentimes for patients who are stage 3A and are able to undergo a surgery up front, they may do so, depending, and it's very sort of patient specific, and these patients are always presented in multidisciplinary tumor board before final treatment decisions are made. And in those settings for patients who do undergo surgery up front, it may even be for a patient who's clinically staged, let's say is an N1 disease, but then is sort of surprise found to have N2 disease. Radiation, I think the most common indications are for patients who may have positive margins or nodal ECE, as these patients were not included on the LUNG-R trial. But it can be a thought of for N2 patients as well, especially patients who have very bulky disease and multi-station disease. And then some of the doses that we include, I think in summary, are something like 50 to 60 gray, just sort of depending on the indication, with gross positive margins getting higher doses and concurrent chemotherapy along with it. And then for patients who have ECE, those patients can undergo sequential instead, with chemo typically administered first. As far as how we would treat those patients, it would be a very, very similar protocol. As far as how we first set them up. So they would be lying supine. They'd have an immobilization device, which is often sort of a board essentially where the arms are up, and so that the radiation beams can traverse the thoracic cavity without anything else sort of limiting the beam angles that we would be able to use, and not treat anything unnecessarily. We would use the PET scan to fuse it, and then target delineation wise for a patient who undergoes surgery up front. We define something called a clinical tumor volume, which is essentially the areas of highest risk, and then have necessary expansions on that. This would be sort of an example plan. The bottom two rows are an example plans for patients who may have radiation plans that maximally try to reduce the dose to the heart, which we know from other trials, including RTOGO 617, that heart health and dose to the heart can affect survival. Here's a sort of a typical plan for someone who might undergo even 3D afterwards. But oftentimes, I believe this is actually a primary disease patient, because I couldn't find a 3D post-op patient example. But typically, if we can, we'll treat those patients with IMRT. For sake of time, I will skip the dosimetric analysis for that example patient. For the stage 3 non-small cell lung cancers that cannot undergo upfront surgery, neoadjuvant therapy, often with either chemotherapy, chemoimmunotherapy, or concurrent radiation and chemotherapy will often be utilized, with a whole host of varying regimens that we'll talk about in multidisciplinary tumor board prior. Here are some of the trials that help define both the neoadjuvant chemotherapy and then neoadjuvant concurrent chemo radiotherapy. So here's sort of a summary of some of the management sort of choices for a stage 3A non-small cell lung cancer, which is that the patient may be a candidate for adjuvant chemotherapy and radiation, either concurrent or sequential, depending on the findings of surgery. And that typically, something on the order of 50 to 60 gray would be prescribed. You would only really go higher than that, or stay at 60 to maybe 66 gray if there's really gross disease or you're treating definitively. Gross disease after surgery or you're treating definitively up front. So a stage 3B patient, for example, as we discussed, would have sort of more advanced T stage and N stage, so like a T3-4 N2, and those patients can be treated up front with just concurrent chemotherapy, chemoradiation. And then the simulation would be very similar to what we described before. A whole host of different regimens. I think most commonly here, most patients will undergo will have carboplatin and paclitaxel, 50 milligrams and AUC2 for paclitaxel carboplatin. But cisotope is another common choice here too. Similar to any radiation plan, including the early stage non-small cell lung cancer plans, will have maximal doses that have been established to help define risk for early and late toxicities for the organs in the area, including, of course, the spinal cord and the healthy lung, the esophagus, and these are some of the metrics that we'll look at. And of course, the heart. These are general ones that I think many institutions follow, and then there's a whole host of others that are listed on NCCN as well. If for whatever reason you can't, from a radiation planning perspective, let's say you have those constraints and you know that they're important to help reduce both acute and late toxicity, but for whatever reason, maybe due to the size of the tumor, its location, and you're unable to meet them. So here are some of the things that you can do, which, some of the most common ways that will try to optimize our plan is to optimize the beam angles first. So oftentimes APPA or something that is more akin to APPA, going straight from the front to the back without much angulation, that can sometimes help reduce, let's say, for a patient where we're struggling to meet volumetric constraints for the lung, they're treating too much of the lung with too much high dose radiation. Even low dose radiation has now also been found to, in some studies, to be predictive of late toxicity. So the APPA or more beam angles that are more akin to APPA can help us do that. And then the other thing that you can do is try to look at utilizing more advanced imaging to help you better define the lesion with smaller margins, and essentially treating a smaller area would help you then, also, potentially treat less heart, let's say, or less lung. The other way to do it is that we'll sometimes do is an adaptive replan, where let's say you tried everything, nothing works, and you proceed with treatment. Of course, you'd have to get informed consent from the patient to make sure that they understand the risks that they would be undertaking with this plan. But there's a fair amount of patients that we'll see somewhere mid-course, because we'll take on what we call onboard CT scans during each day of the patient's treatment to make sure that the way that they're aligning on the machine, the way that they're breathing, the way that the tumor is moving is all consistent with what we planned for. And so on those CTs, oftentimes we'll see that there has been response. And so somewhere midway in the course, we may replan them to now what is a smaller tumor. And that can sometimes help us meet our constraints too. Of course, we'll have to, discuss with these patients, the recommendation for consolidative immunotherapy based off of the Pacific trial. Patients did have, wasn't quite a doubling, but almost, of overall survival for patients who had response, to, these stage 3 patients who had response to, and no progression to definitive chemotherapy and radiation treatment, and longer progression-free survival, longer time to composite endpoints of death or distant metastasis. And so, these patients will often undergo durvalumab afterwards as well. For the sake of time, I'm gonna move through the superior sulcus tumors. They're sort of a special consideration that essentially would get neoadjuvant treatment with chemo and radiation, followed by a surgery, ideally not a pneumonectomy, but a lobectomy for these patients with a superior sulcus location. But I'll skip the details of that just due to time. The the other sort of main disease that we see in this space is small cell lung cancer, and that's defined by either limited or extensive involvement. With limited, traditionally meaning that it would fit within the RT portal. So, all treatment machines, old or new, have an absolute size aperture, size of the region where the radiation is actually emitted, um, and limited stage was defined as something that could fit within that. And then extensive stage is something that maybe beyond that. And I think the AJCC staging is still of course helpful for these small cell lung cancer patients too, but oftentimes it's really this limited versus extensive stage that we sort of think about and talk about and decide management with. The smoking, similar to non-small cell lung cancer, but even more so here, can be, a very, very highly predictive risk factor. These are typically, the small cell lung cancer is typically seen on histology as these small round blood cell sort of tumors with certain paraneoplastic syndromes that can sometimes go along with them. And a large majority of these patients will present with extensive stage disease. Which I suppose is quite similar to the non-small cell lung cancer patients globally as well. A brief review of just the small cell and non-small cell paraneoplastic syndromes. I typically think of metabolically, at least, hypercalcemia going along with the non-small cell, and SIADH and ACTH going along with the small cell, and of course, each of them have others too. Other syndromes too. So for the small cell, early stage small cell lung tumors, surgery is an option, and patients can undergo surgery too. SBRT is uncommonly utilized, and oftentimes these patients will undergo surgery, but could be considered if for whatever reason surgery wasn't an option. Concurrent chemo RT as being sort of the most common approach for these early stage limited stage patients. 45 gray in BID fractionation or twice a day was sort of the established standard. Convert was a trial that looked at the dose and fractionation differences on a non-inferiority basis between 45 gray BID and conventionally fractionated regimens. So daily treatment over about 6 to 6.5 weeks. It was found to be non-inferior, and I think a lot of patients had a lot more ease, both in their schedules, because some of these patients will continue to work, of course, during treatment. Sometimes health insurance related, sometimes sort of financial related, sometimes choice related. Patients will work throughout, and so the daily treatment is sometimes easier for them to actually make it to each day. Because there's a non-inferiority trial, so what I'll try to do is treat patients with 45 gray BID, and then if for whatever reason they're unable for all of those aforementioned regions, we'll treat them with conventionally, daily fractionated daily treatment, and I'll go over the convert trial with them. TCI, the RT sort of the radiation planning, there's some similarities. I think we do use PET still here as well, as far as workup and management, and we're able to fuse it and use it to help define our target and treat them with radiation. The setup is pretty similar to what you've heard of before, and then the max doses to the surrounding organs are different between the BID and the daily treatment. And so, we're mindful as to the surrounding doses. pneumonitis is increasingly becoming sort of a uh, uh, sort of an important consideration, especially as immunotherapy starts to enter the world of small cell lung cancer in both limited and extensive stage patients too. So that's something that we're now even more careful of. So PCI. So I think most commonly now, many patients, I think likely most patients will still undergo PCI standard of care, and as there is evidence that it improves overall survival and certainly decreases the rate of brain metastasis developing in these patients. The sort of criticisms of this approach, I suppose, are that a lot of these earlier trials weren't able to and didn't use MRIs of the brain, and so the idea is that potentially the overall survival benefit that's seen could be instead due to gross disease that was present but unknown at the time that these trials were done, and that this, especially small cell being a fairly radiosensitive disease process, even the lower doses of PCIs compared to whole brain radiation treatment, that these patients could have responded, and that's maybe why we see it. But there are some ongoing trials, including Maverick, which is trying to ascertain whether or not, similar to extensive stage patients, MRI can instead be utilized upfront, and close MRI surveillance as opposed to upfront PCI. And dose-wise, there hasn't been a benefit to higher doses, and so we typically stay with the 25 gray and 10 fractions daily. In the extensive stage, in the limited stage cohort, Adriatic was an important finding, published, had to been within the last few years, maybe 2 or 3 years, and adjuvant durvalumab greatly improved survival progression, overall survival, progression-free survival, and no sort of concerning safety signals in the long term, with the addition of this for these patients. But again, we as radiation oncologists, we really have to be mindful of pneumonitis risk for these patients, and how we're designing radiation with the understanding that they are likely going to go on to this next phase of treatment. In the extensive stage cohort of patients where the backbone of treatment is systemic therapy, carboplatin and etoposide, commonly atezolizumab, the addition of atezolizumab has also been shown to be of benefit. Here, the survival differences were a lot smaller as compared to the limit stage cohort. As far as when we see them back, we'll see them back with CT scans of the chest, abdomen, pelvis, and the MRI of the brain, importantly as well. And we'll often see them on a sort of 3 to 6 month basis. Right. I very briefly touched on PCI2. Usually what we'll do is we'll treat the thorax first, and then assess for response, and then see them back and plan for the PCI afterwards. In extensive stage, similarly, there are trials where earlier seminal trials where PCI was given as well in extensive stage, and thoracic radiation for patients with response in the chest, consolidated thoracic radiation, that had been shown to be of benefit. But then in a Japanese trial, Takahashi had sort of looked at patients who had extensive stage small cell lung cancer, and had them either undergo upfront PCI or MRI surveillance, and it didn't seem as though there's a benefit to upfront PCI in this cohort of patients, and so for that reason, many extensive stage small cell lung cancer patients are instead followed with MRI instead of PCI. And that Maverick trial that I very briefly discussed prior is seeing whether or not that may be true also in that limited stage cohort. So as a brief summary for the small cell lung cancer patients and limited stage concurrent chemo RT, and either a twice a day or a daily treatment option, and then PCI for those with response, and many of these patients do have that. And then for extensive stage, that one could consider either consolidative thoracic radiation and PCI, but oftentimes that PCI is deferred instead for MRI surveillance. If they do undergo consolidative radiation for the extensive stage patients and who get response from upfront chemoimmunotherapy, 30 gray in 10 fractions is often what we use. And I believe that is it. Sorry for the mad dash at the end. And so if there are any questions or anything that you want to go over a little bit more in detail, just let me know, and we can talk about it. I still have some time.
All right. So thank you very, very much, Dr. Mo. That was a lot of information in a little time. I did struggle to keep up, so I hope everyone understood as much as they could. I did write down a couple of things that I hoped to ask you to clarify. And if I can just ask everyone to mute themselves so that there's, let me see, Dr. Abba. I'm not sure who this is, actually. Okay, so please, everyone, mute your microphones just so that there's no interference. If there's any questions, feel welcome to put them in the chat or to raise your hand if you would like to speak very briefly. I wanted to just ask if you could one more time go over the GTV, CTV, ITV, and then the IGTV. You talked about that earlier on. I also see Dr. Verna's hand up. So Dr. Verna, please do go ahead and unmute yourself if you want to make a comment or ask a question. And if there's any questions, please feel welcome. Type your questions in the chat.
Okay, maybe I missed it, but what's the clear indication for PCI in extensive small cell?
Okay.
Sorry, I think I muted myself. For extensive stage small cell, we typically don't do PCI here. We will now just follow them with MRI of the brains instead. Of course, if someone presents with gross disease, that's of course something different. But in patients where there is no evidence of gross disease, they've been appropriately staged with an MRI of the brain, we'll typically just follow them with MRI instead.
Okay. So we just want people to know that it's changed. The status quo has changed, so we have to keep up with the new recommendations. So it's not like stringent like it used to be before. So thank you.
Right. Absolutely. And then so the planning, radiation planning, oftentimes what we'll do, and this is pretty consistent no matter the site. I think the way in which we think about some of the expansions differ depending on the site and what we consider to be at-risk tumor volumes change. But the very sort of overarching thesis for how we think about planning, radiation planning, is consistent across sites, which is essentially, if there is gross disease, we're treating something upfront definitively. Like in this setting, we will define a GTV volume or a gross tumor volume. SBRT, this is maybe not the best slide for this explanation, because SBRT often we don't think of as putting on a CTV. So let me see if I can get to a different, we often don't think of it as putting on a CTV, but instead we'll go straight to an expansion from gross to planning. One, there had been arguments as to whether or not there truly is or should be a CTV for SBRT patients. From our surgical colleagues, we understand that the pathological studies for squamous and adenocarcinoma would indicate that the subclinical tumor volume that's surrounding the primary tumor at risk might be something like 6 to 8 millimeters outside the primary tumor, just based off of resection pathology slides that would indicate that there are some cells that would exist, beyond what we see in the gross and the sort of that gross tumor by something like 6 to 8 millimeters. And so some people argue, well, even for SBRT, if radiation is meant to be a sort of replacement, so to speak, for surgery, that we should do something similar. But many of the initial trials that looked at SBRT did not plan it that way. They delineated a gross tumor volume, and then they expanded to a planning tumor volume without any CTV, and that seemed to show still excellent results that were somewhere around where within 5% roughly of where some of the surgical colleagues' local control would be. But typically, for other outside of the SBRT setting, we'll look at a clinical tumor volume, which is sort of site by site specific, but it's what we think of as where and how far away there could still be some subclinical cells that are not radiographically apparent or otherwise apparent clinically, but exists and should be included within the radiation treatment portal. And so oftentimes that will lead to expansions, and sometimes inclusions of either lymph node pathways and that sort of thing. In the lung cancer setting, the CTV for locally advanced tumors is often somewhere on the order of 5 millimeters or so. That's sort of a good sort of benchmark to remember as for expanders, but it does differ somewhat. It may be as great as 8 millimeters, and for the nodal volumes, which we also delineate as gross tumor volume, or then with expansions, may include actually the entire nodal station, just sort of depending. But the CTV can always be thought of as where do we think there could be additional subclinical cells that we don't see radiographically but still exist. And then the PTV, the planning tumor volume, that's really just a setup error, essentially. So thinking about putting a patient on the table in the exact same location over a period of 7 weeks is difficult. And so we put on some error volume essentially that says somewhere within 5 millimeters, let's say, would be acceptable. But if we set them up in a way that's beyond that, and so that's where the PTV comes in, and 5 millimeters, I suppose, could also be a reasonable sort of benchmark. These numbers change a little bit from department to department. Some departments will have excellent sort of experience and feeling as though their setup margin, their difference from a single patient day to day is quite small, and that the utilization of certain techniques like onboard CT imaging daily could help reduce that. And so they may go with different numbers than what I presented to you, but those are good benchmarks for, I think, a lot of departments.
All right, thank you very much. We're going to wrap up very soon. Just 2 more questions I wanted us to address. When there's limited access to a PET-CT, what advice do you have to try to get as good coverage as you can in situations where there's no access or there's limited access to PET-CT or image? Yes.
I would say from a radiation planning standpoint, especially for the early stage non-small cell lung cancer patients, I think PET-CT might have a sensitivity for peripheral lung tumors that are small, on the order of, let's say, 2 to 3 centimeters, of something like 90%. Meaning, if there's no nodal positivity on a PET-CT for a peripheral lung tumor, you can be more or less confident that it doesn't in fact exist. For central lung tumors, that differs, and so I think meaning the sensitivity drops. And so for central lung tumors that would be negative on PET, you're not as certain. And so I think in the absence of PET, especially for patients with early stage lung tumors, lymph node evaluation becomes even more important prior to administering definitive radiation treatment, because we don't have that information as of lymph node involvement to the same extent. CT, of course, can show gross changes in size, but nothing metabolically. And so I think, and then so from a management standpoint, I would say lymph node evaluation becomes even more important. And then from a planning standpoint, I think margins could be increased. If you feel as though the exactness of the gross tumor volume, and the same can be true for 4D CT, for example, if you're in a simulation setting and there's no access to a 4D CT, then instead of, let's say, a 5 millimeter expansion, you could go with something like a 10 millimeters expansion, just to feel a little bit more confident that you are in fact getting the entirety of the disease.
All right, thank you. So just two more questions that I think will help put everything in perspective. So the first one, and I'll ask both together. So the first one, I'd like to ask myself, what are some errors or common errors that you think you've seen or are documented when it comes to planning or contouring, for long radiotherapy? What are some errors that are common and that people should keep in mind and try to avoid? And then in general, for early career oncologists and physicists who aren't very familiar with thoracic radiation, what are things that you think might be important to focus on to help build confidence in long radiotherapy? Thank you.
So I think one of the most common planning difficulties up front, especially for patients with longer standing lung disease and smoking history, is that there may be multiple nodules and maybe only one of them actually looks malignant appearing and has serial growth. And so making sure that you're getting the right one, especially if a patient doesn't undergo path confirmation by biopsy, is extremely, extremely, extremely important. I think that from a planning perspective, thinking about heterogeneity and homogeneity calculations for lung tumors are important. As radiation traverses lung tissue, which is mostly comprised of air, it has a certain amount of interaction with the lung, and there are different models that can be utilized to calculate radiation dose, some of which take into account the differences in density and between the lung and the tumor, and others don't. And so to make sure that you're using the appropriate model, or that you understand which model even that you're using to help calculate that dose, can be helpful, because that can change how much dose is administered, just based off of those homogeneity and heterogeneity calculations. And then so that's I think some of the common things to think about when starting. And then for the second question, can you remind me of the second question again?
Yeah, so I was saying that for earlier career oncologists and physicists who aren't very familiar with long radiotherapy, thoracic radiation, or for units or centers where, we're just beginning to, practice it or haven't practiced it as often, what are some of the core things you think are important to focus on in order to build confidence?
Right.
So I guess that's just sort of like a soft skills question, but I think it might be a good way to wrap up the session.
I think some of the things to focus on earlier on, from a clinician standpoint, is likely going to be patient selection. I think the decision to treat and not to treat, and how you treat before you even get to the planning, is maybe one of the most important pieces. For people with central lung tumors versus peripheral lung tumors, the risk for radiation may differ, and your choice of dose and fractionation may differ. And I think really focusing from a clinician standpoint on patient selection is important. From a physics and dosimetry sort of standpoint, I think that some of the most important things to to focus on are they'll probably still be the heterogeneity and homogeneity corrections, and then tumor movement. I think those two things are probably, and to gain confidence in by really just making sure and spending time understanding how the tumor may move based off of the imaging that you have. Breath hold technique is a good way to ascertain, especially for the hypofractionated and SBRT regimens, to ascertain tumor movement in the absence of a 4D CT. So asking the patient to hold their breath for something like 20 or 30 seconds, doing the CAT scan while they're holding their breath, and then doing that, let's say 3 times, and really making sure that your planning scan and the other scans that you took, that the gross tumor, the IGTV volume that comprises all of it, from a physics standpoint, is a second check. Well, that's important. I think those are probably the things that I would focus on to first.
Thank you very much. So there's a question in the chat, and just before I read it out, I just want to explain and apologize to everyone. I seem to have sent out my personal registration link. So there's multiple Adedayo Josephs in the in the participant list. So if you don't mind, please go ahead and rename yourself so we can know, we can get to meet you and know who's in the meeting. So this question is asking about contraindication to radiation for lung cancer. Do you want to unmute yourself and ask your question live? Adedayo Joseph.
Okay, Adedayo Joseph. Thank you very much, Dr. Adedayo.
And then ask your question.
Yes. So thank you very much, Dr. Mo. So the question I want to ask is on the aspect of the contraindication. I know there's a slide you talked about indication that you will not do radiotherapy. I know you talked about the size and the sites. I would like you to talk more. I just need some clarification there.
Yeah.
Then again, in this part of the world where we have large tumors, especially with the lungs, most of our patients come late. What would be your advice? Thank you.
Absolutely. So as far as the size criteria, I think a lot of folks are most comfortable with a 5 centimeter or smaller for the ablative approaches, like the 50 gray and 5 fraction as a common regimen that's utilized. The reason is, I think, that trial, RTOG-0813, looked at mostly central tumors, so tumors that were within something like 2 centimeters of the proximal bronchial tree, with the understanding that the prior RTOG studies that studied this approach used a higher potency of radiation when they delivered it, and so they wanted to look at these central tumors, but had a size limitation, with the thought that very, very large tumors may either not respond very well to this approach, or this approach may be too highly potent for the surrounding tumors, for the surrounding organs, excuse me. So in close proximity to, let's say, the heart or the blood vessels that surround the proximal bronchial tree. And so for that reason, I think most people are most comfortable with 5 centimeters or smaller. For ones that are larger or more central, let's say maybe even touching the proximal bronchial tree or touching the heart, for example, very, very central, ultracentral tumors, a lot of practitioners will instead decide to do something that's a hypofractionated approach instead. So 60 gray and 15 fractions. So essentially spreading out the dose is how a lot of people will, instead of doing it in 3 or 5 treatments, they'll do it in something like 8 to 15 treatments, and they'll do that instead. We'll do that here too. We'll see patients with very, very large tumors, and that's we'll usually sort of go more towards that with the idea that spreading out the tumor dose may be safer.
All right, thank you very much. I believe there's no more questions or comments We have 7 minutes and then we'll be wrapping up if there's any last words from anybody. But in the absence of that, Dr. Mo Hisor, thank you very much for taking the time to speak with us and to teach us. It is a bit of a complicated topic. We're going to be having, it's a whole series. This was just the first of the series. And hopefully as we keep going, we'll, learn more and more. I hope we'll have another opportunity to chat with and learn from Dr. Mo, and look out for emails from the Secretariat with the slides if possible. And then, hopefully we'll have the recording up on the YouTube page or Aortic website. If you're not yet a member of the Radiation Oncology Special Interest Group, email special interest groups at aortic-africa.org to indicate your interest in joining. If you have any questions, feel welcome to email me personally or email our speaker, Dr. Mo Hisor. I put his email address in the chat if you want to send him an email. And thank you for sharing your email with us for us to be able to reach out to you. So again, thank you everyone for attending. Thank our speaker for teaching, and enjoy the rest of your evening. And thank you to the Secretariat for helping to organize this meeting.